Put the camera so that you can look into the camera.
Mhm.
Put the camera so that you can look into the. Okay, we are ready. We are online.
Hi, guys. Thanks for watching. This is Essence of Medicine. Today, we're going to be talking about who needs spine surgery. I'm Amanda Armagast.
Dominic Moore.
Sienna Aya.
And here's Dr. Abbasi for Essence. Now, we have here non-medical personnel. Amanda, that's you. And we have a physician assistant. What is that? What would you say what that is?
Usually we call it sort of like a mid-level, you know.
Well, I thought that's a bad word.
Honestly, no, it's appropriate. There's a lot of people that think it's not. Nah, screw them. They don't know.
I actually like the word mid-level because I feel like it really helps people visualize things as nerves.
Halfway to the
Yeah.
Yeah,
Midway there. I use mid-level manager all the time.
And then we have Dr. Aya, he was a orthopedic spine surgeon. And then we have me, I don't know who I am, but more or less, the mid-level is supposed to be somebody that between the Amanda and Dr. Aya, that somebody that between understand enough from, the expertise in the surgery, and but it's not obviously trained to perform the surgery by themselves. Now, but let me ask, first start with Amanda. Amanda, spine surgery. What do you understand when somebody tells you they had a spine surgery?
So maybe 5 years ago, I would think a little bit differently. 5 years ago, I would think that someone who had a spine surgery probably had a very invasive procedure done where I would assume there was a large incision on their spine, and then obviously a doctor went in and fixed a problem that they had. Now I would think about it a little bit differently. I would think if someone had a spine surgery, obviously they still had an invasive procedure in the spine, but there's a lot of different options now. So I wouldn't assume immediately that it was a very invasive procedure, like with a long recovery and a lot of damage, still to solve the same problems though.
Yeah, so practically you would think that somebody got a cut in the spine or close to the spine, and the surgeon went there and fixed something in the spine.
Yeah.
Now, that something, Dominic, what is that something that we fix in the spine? Can you just, from your knowledge base, tell me what do you understand under my aunt got spine surgery?
Gotcha. So traditionally, when there's spine surgery, a lot of people still think of the scoliosis, you know, those big things, and they imagine you just kind of go in, dominate the spine with a million rods and screws, and you build this whole railway system. But really, at the end of the day, you know, we find patients and they have one level that's a spondylolisthesis. Essentially, the spinal cord is doing something like that. It's not supposed to, or some other degenerative change or something going on with the facets that let the nerve roots out. And we can go in and we can give a little more space or decompress at just specific levels, which is a lot nicer. It's a lot more in line with what people think about when they think of, oh, you know, I had some sort of knee injury. I had to have, like, you know, something kind of maybe an hour or two, go in, get that fixed. So that's a lot more of what modern spine surgery feels like.
Yeah. Well, Dr. Aya, what would you say if somebody says, I had spine surgery? What comes to your mind? What you understand under spine surgery?
I think it's surprising just how much trust patients have when it comes to the ability for them to give surgeons access to their body. You'll have somebody come in and say, yeah, I can't really remember, but I think somebody did something, you know, to my spine a couple years ago. And you'll take a look at their x-rays and they are fused from like T10 to the pelvis, front, back, screws, rods everywhere. So what I've come to understand is that a lot of patients don't fundamentally understand what spine surgery actually entails. But when a patient does come in and they say that they've had some kind of surgical procedure done to their spine, the things I think about is what were the indications? Was it to restore alignment? Was it to decompress? Was it to do some sort of deformity? Was it for an infection? Was it for a tumor? And then afterwards, did they have a complication? And then more importantly, did they do good, right? So
Well-
those are the things that come in mind. What did they do? What was done? Why was it done? Did they have any complications from it? And did they do well?
Well, yeah, as a surgeon, saying somebody had spine surgery is like saying somebody has a car or vehicle, even worse.
Yeah.
Okay, meaning that, do they have a moped or do they have a space shuttle? Do they have a semi?
Mhm.
If it's a Toyota, is it a Toyota Camry or is it Toyota Prius?
Or
If it's
Lexus.
or is it a plug-in hybrid? So you see, as a surgeon, that it's very nuanced what it is. Like, this is a spine surgery, where there is a cut in the middle, the skin is pushed to the side, as you see here, or maybe this picture here. Then literally, we access the pathology. The pathology, meaning, what does mean pathology? When you hear Amanda pathology, what does it mean to you?
Like what the problem is?
Yeah, very good, actually. What the
Amazing.
problem is.
Thanks,
Nailed
guys.
it. Well done.
Thank you.
Yeah. Now, the pathology in the spine, there are categories of pathologies in the spine. Dr. Aya, do you want to describe to us what categories of pathologies in the spine exist that would require a surgery?
So when I think about pathologies, and I think about the different tenets of spine surgery. So things that could lead to a person getting surgery for the spine, degeneration, where you have nerve or neurological issues that are affecting with the activities of daily life. You could have trauma that leads to spinal instability. You could have infection that is not able to be treated with just IV or oral antibiotics. And then you can have tumor. Unfortunately, the spine is a common area of mets from different types of cancerous processes. So tumor is also one. And then with the pediatrics, you can have deformity, which is scoliosis, but then you can also have deformity in the adult, which isn't as much scoliosis, but more of a kyphosis type of process.
Yeah, well, you practically described not only for the spine, but for entire medicine. So, Dominic, if you want to know anything in the medicine that we treat, is either you're born with it, it is practically inherited, or it happens after the birth through a trauma, number 2. It happens through a tumor, number 3. It happens through aging process, degenerative, or it happens through a bug infection, 5.
Okay.
So is there any other disease in the history of human being that is not through one of these 5 things? If there is, I'm not aware of it.
I can't think of anything.
So I see Dr. Aya has some problem here with the monitor and so on. So for the spine is no different. We have 5 reasons that Dr. Aya described to have a pathology in the spine. Now, from all those pathologies, at the end of the day, there are 2 things that we are treating in the spine. Now, Aya, you get the lollipop if you tell me at the end of the day what those 2 actually problems are that all these 5 different things cause that we fix. What are those 2 things?
Pardon, sir?
So those 5 categories of pathologies, at the end of the day, they cause 2 syndromes or 2 problems that we fix in the spine? What are in the spine? Two category of symptoms and syndromes and so on are that all those 5 category cause and we fix. What are those 2 things?
I'm going to try and read your mind, but my guess would be neurological issues, which could be compression of the spinal cord or compression of the nerves that's causing functional deficits or pain. And then alignment issue or deformity issues or instability issues. Those
Yeah,
are the two major
You
things.
named it, compression or instability. Okay, so you see, we can narrow it down from those 5 categories to only 2 categories, compression or instability. Like, can you give me an example for compression?
Compression, so classically in degen, you have myelopathy, where you have degenerative changes in the cervical spine that can compress the spinal cord. It could also happen in the thoracic spine. And then
can you describe this one? Are you able to see my screen?
Not really.
No? Let me unshare and share again.
Okay, I saw it for a second. It looked like a herniated disc.
Okay. Are you guys able to see that? Let's
Yeah.
start with Amanda. Amanda, what do you see?
I see, looks like, shoot, I don't remember what that stuff is, but I remember you guys joke about it looking like crab meat.
It does look like crab meat.
Bad disc.
Yeah.
That's my answer.
So, but let's start with the MRI. Dominic, what do you see?
Yeah, I'm looking at, looks like a herniated disc at L5S1, and there might be some modic changes as well, but I can't.
Nice. Modic changes. You just jumped to it. What, now that you had said modic changes, what grade?
It's looking, I mean, it looks kind of fatty, so I would go with 2.
Yeah? Aya, what do you think?
I would say 2 as well.
Yeah, 2 or 3, I would say. There's lots of bone marrow changes and so on. I think, but the disc height is preserved. Do you agree with that?
Yes, sir.
Yeah.
Okay. Now, let's talk about this patient because we talked about 2 situations that we do surgery for the spine, right? This is the compression. What does it compress, Dominic? What does this finding compress? By the way, you want to describe the picture, like a classical description of these pictures? Do you want to classically describe these pictures?
I think I might be missing classical description. Are you talking just where we're going for bone, muscle, that sort of thing?
No, I mean, if you were in a conference, you would be, or in a, presenting this to your attending, how would you describe that? How would you describe this picture to me?
Age of the patient, past medical history, presenting with acute, subacute.
Perfect.
Findings
Identification of the patient.
on a MRI T2 sagittal view.
Yes, you got it. That is a classical description and presentation of a patient. Patient identification, patient short history and relevant information, symptoms, and then identify what modality it is. It is CT, is it MRI, is it X-ray, is it ultrasound? And in that modality, what sequence it is. This is a T2 on both areas, and it's a what plane? Is a sagittal and axial T2 of the lumbar spine, and so on and so forth. That's a classical description. Okay. So now then we jump into actually we say that patient has L4-5, 5S1 disc disease with modic changes or end plate changes. You can as well, use regular words. And then you describe that there is a very large disc herniation in the L5S1. And what else would you describe it, Dr. Aya, in this picture?
The disc is extruded,
Yes,
and then you'd also describe that it is still congruent with the disc space.
that is important information
That's
because in the
important.
surgery you must follow it. Okay.
And then you describe the location. It is paracentral,
Okay.
central paracentral. And then there's central and lateral recess, and maybe some foraminal.
Yes, good.
Stenosis.
So it's a central, paracentral to the left, sides are switched.
Mhm.
Yeah.
In this picture, definitely a lateral recess stenosis, possibly foraminal stenosis, but you cannot say that just from this picture, correct? Okay, so this material, whatever it is, we are talking about indication of the surgery. This material is pushing on the nerve. Dominic, what symptoms do you expect for this patient?
Well, certainly pain, but also at this point, with that level of herniation, you could eventually get, numbness, that tingling.
Mhm.
I
So
mean, of course, functional weakness there, either whether it's from pain or just generally they're not going to be doing it.
how bad this pain could be?
Oh, I mean, this is going to probably be the worst pain in their life. You could have a patient
Yeah.
come in, rather have a rusty saw blade go through their knee
I have
than
a
this.
question.
Yes.
So with this area of the spine, where would the patient be feeling the numbness and the tingling? Would it be in like legs, arms?
Yeah, good question. So, Dominic, what do you think?
Yeah, so this is going to be shooting down the legs. This is going to be very lower extremity stuff. Honestly, we'll probably shoot around the back. You might get some that eventually radiates down to the ankles, but it's going to be very similar on both sides. It might even be one-sided, closer to the left side, depending on
Mhm.
they're having.
So,
a-
Dr. Arya, what do you expect the symptoms of this patient be?
Leg pain greater the back pain. The leg pain should go down past
That
the
is a
knee.
very good description. Leg pain worse than back pain. Why?
Because of the location of the disc herniation, and also because in general, even with a pure central disc herniation that doesn't affect lateral recess, back pain is not really too severe. It's not really a good predictor of how they'll do.
Now, it is not a good predictor, but that is not that's truly not the fact that the reason I wouldn't expect much back pain on this patient is because of the disc height. Look at the disc height, it's
Yeah.
more or less normal. Now, let's talk about the back pain. I know your university education was very close, and in the universities, they do not believe in the axial back pain.
No.
They don't say they don't believe in that. They say that's a very bad predictor of the outcome. So don't include that in your algorithm. I completely disagree with that.
In layman's terms, what do you mean when you say axial back pain?
Meaning that pain in the lower back, in the middle of the back, in the spine, where actually the problem is versus pain that goes down the leg, which is the radiculopathy.
Okay.
Now, yeah, that is, bring us back to the down that other people can understand us as well. Very good. So, let's talk a little about the spinal anatomy. How much of the weight, Dominic, do you think is carried in where the bone and the discs are? What percentage of our weight is carried in the front? And what percentage of the pain is carried in the back where the facets are? Let me get the anatomical picture here. What do you think? Yes, something.
Yeah. So my estimate, this is guess, I'm going to go with interiorly, we're probably going to carry a little bit less, it looks like. I would say probably somewhere close to 40, 50, but then
Here?
posteriorly on the very back of the lumbar.
Okay, on the facet. So here, that is what you say, that the 40, 50 of the weight is carried here, and the rest, the other half is carried in the back. That's what
Sorry. Reverse it for me. I'm going to say about 40, 50 in the facets back there, but then where the disc is, I'm going to go with 80 at that point, closer to 80.
Okay, 40 and 80 makes 120. Where do you get that? The rest of 120.
They share.
So, Dr. Arya, what do you think?
80% anteriorly, 20% posteriorly.
Perfect. So most of the weight is carried in the front. Now, what happens if that distance between the disc collapses? Literally, that area is not carrying that fair share. What do you think going to happen here? This here, look at the distance. Imagine the bone is on bone. What's going to happen?
Yeah, it's not going to carry that weight very well. It's going to hurt.
Well, the rest has to be carried by the posterior element, but the facet growth, the facet grind. Facets are more or less true joint that are supposed to get 20% of our weight. Now all of a sudden they have to carry 50%, 60% of our thing. You get facetogenic pain. You get axial back pain. Part of the pain as well, we know these days that as well is generated by a nerve here in the disc. So the discogenic pain that some academics say doesn't exist, we have a very good evidence that when the disc is incompetent, you have pain in the disc and the pain in the back, facetogenic pain, discogenic pain. Dr. Do you want to describe a little about those facetogenic pain, discogenic pain? What sometimes even we do something for that. What do we do for that?
So facetogenic pain is a very interesting diagnosis because a lot of people think that it is a precursor to signs of instability. So some people are actually injecting the facet, and if they get a good response, they're using that to diagnose micromotion, but that's besides this talk. Facetogenic pain is pain that's located mostly in the paraspinal regions. It's worse with extension and rotation. It doesn't tend to radiate too much outside of the location of the facet. And the standard treatment is to do a series of diagnostic medial branch blocks, MBBs. And then if that is successful, then go ahead and do an RFA ablation of the nerve that goes to the facets.
What is the nerve called?
The medial branch.
So, and that is right here, that nerve that we are talking, that we injected first, and then, so coming back to our picture, the reason I expect mostly here leg pain and not back pain is because look at the chunk here, it's pushing on what nerves? Dr. What radicular, what nerves do you expect to have symptoms in this specific patient?
Mostly S1. If it is lateral recess, if it is in the foramen, then L5, but mostly S1 symptoms.
S1, as a matter of fact, if you get a herniation in any disc, 80% of the time you get the lateral recess symptoms, meaning the nerve that passes go down one level below it. And then 20% usually in average, you get the symptom of the nerve that goes out same level. And the reason for that is actually very trivial. Here, this is not the accurate description. The nerve actually takes off very close to the up here, where just the pedicle is. So that disc, when it bulges out, 4 out of 5 times, or 80%, it pushes on the nerve that passes through to come out the next level down. So, and to only 20%, you get the symptoms of the same level. Now, here, obviously, what surgery did I perform, Dr. Aya?
You did a microdisc with a tube.
Did I do a fusion? Most likely not, right? Why not? Why would it be wrong to do fusion, or why did I in this patient decided not to do OLIF? Because I can do OLIF. Just 2 days ago, I did a OLIF in 26 minutes. This is a 40-minute procedure, so I can do fusion faster than microdiscectomy. But why did I decide in this patient I did not do a fusion on this patient?
There are classic indications for a fusion, especially an interbody fusion, and an acute disc herniation isn't one of them. These people usually do really well with the decompressive surgeries.
So see, Dr. Aya, certainly we have those classic description of the indication and so on and so forth.
Mhm.
But I think we in Inspired Spine, we are somewhere, we challenge those indications, we set up the indication for the future. Let's not go what we have learned in our primary school and kindergarten. No,
By that you mean residency.
now we write those textbooks.
Yes.
Okay, let's come back after having done the authority in the world for this kind of things, talk about why we decided not to do a fusion, even though we can do a fusion much more efficient, faster than a macrodiscectomy. Now, this specific patient did have very, very little back pain.
Mhm.
Okay.
Mm. I'm actually particularly invested in this case because this looks very similar to a patient I had seen recently, and she was very curious about surgical options. And and I'm going to say this with pride, a mid-level, had to tell her there's a variety of surgical approaches, of course, but that's discussed by a surgeon, whatnot. I can explain some of the procedures to you, but which ones are going to be more indicated versus others, I can only limit it so much. So I am very, very curious, as well as knowing, indications for an OLIF from our perspective as the leads on it. I kind of want to know what things would we add on to this to then go, all right, go for fusion.
Okay, well, do you remember when we talked about two categories of pathologies at the end of the day that we treat? What were they?
We have those beautiful compression and instability.
In compression and instability. So let's agree in a bigger picture, if there is compression is the only problem, then we just decompress. Go ahead.
Compression, instability, and deformity, like the scolies and the T10s to pelvis.
No,
Because there's no instability.
Well, deformity can cause compression, can cause instability, can cause both of them, or treatment for scoliosis can cause either of them. But at the end of the day, even deformity comes down to compression and instability. Like you get a patient that that spine with that Cobb angle side bending is not going to be sustainable, is not going to be stable in the long run. I challenge the idea that deformity by itself is an indication for surgery. I challenge that because at the end of the day, if somebody, and I get lots of patients, I just did a surgery, our best patient is that the one we did in our surgery center, has a huge deformity, but has no symptoms from it, has a huge compression in the thoracolumbar region. We just did that surgery, remember? You're called every few months at Dominique checking on that patient. The patient had a previous fall and from tractor, broken back, and for 35 years with a severe thing, the compression and deformity living, but bone has grown in that situation. Nerves have adapted to that.
Yeah.
It's even though it's causing some compression and some deformity in the picture, it does not cause any symptoms of deformity and compression or instability clinically. So we didn't do anything for that. We did the surgery for grade 2 L5S1 spondylolisthesis that was causing symptoms. Now, so compression, you decompress. Compression alone, you decompress. While you are decompressing, you have to take so much bone away that all of a sudden spine become unstable. And what do we do then? We fuse. So decompression, we decompress. By instability, we fuse. Now, let's talk about what the consequence. You see, when there's a difficult situation, you have to break it down into its elements. Then you can deal with that. You get the patient comes with 50 different problems. You give up. But you start with one problem. We start with one symptoms. You break the problem, complex problem, many small one. You fix the most severe one that patient could benefit from, and then you move on and move on. once you solve enough problems, then you have helped the patient. Now, let's come back to that. Break it down, 5 pathologies to compression versus instability. But you have to understand, sometimes you cause, as a surgeon, you cause instability. You have to, because that's the only way to take the pressure off. Like one of our mostly performed spinal surgeries is what we call TLIF. Dr. Aya, describe, what do we do in the TLIF?
So TLIF is a interbody fusion technique where you remove the facet traditionally on the side of the radiculopathy, because the theory is this is the nerve that's already damaged. And then through that space, you gain access to the interbody space, do your discectomy, and then put in your cage, and then put screws in at the back like other traditional surgeries.
So now let me tell you how we found out about this. This is a good surgery, often performed, but it's about 40, 50 years old technique. Before that, we used to take the inner part of the what we call facet off. And then we noticed that to get access, we still do that. When we do a decompression, we still take part of the facet off to get access to the spine. That's the only way from the back to get access to the spine. But then we noticed that if we remove more than half of the facet, that segment can become unstable. Especially, what is the criteria for instability after decompression, Dr. Aya? Let's talk specific. You have learned that in your school and so on, but the criteria right now for instability is if you remove more than half of the facet and violate the disc.
Yes.
You can violate the disc, remove less than half of the facet, or you can violate more than half of the facet but not touch the disc. You still can, rule of thumb, consider that stable. But if you do either of those, based on lots of studies that we have done, lots of surgery that we have done, we call that, what name do we have for that, Dr. Aya, when we cause instability?
Iatrogenic instability. Question I have, because a neurosurgeon told me that with the thoracic spine, because of the ribs, you have a little bit more leeway. Is that
That's true. That's true. You have your own brace internally, and thoracic spine, they have okay, let's talk, now we are talking about cervical, thoracic, lumbar spine. Obviously, the more motion, more instability. What is the most motion in the cervical spine, Dominic? What levels?
Oh, goodness.
Akaya, where's the most most motion in the cervical spine?
Occiput C1. That's a lot of motion.
For the
For the subaxial, 5-6.
5-6. Okay. Now for turning your neck back and forth, occiput to C2 or C2, C1, C2 actually. For the rest of the motion, C5-6 is the most of the motion. In the lumbar spine, it's mostly L4, L5, L5S1, that's the most mobile. And that's exactly where we see most of the pathologies, not C1, C2, okay? C5-6, L4, L5S1, L4-5. For that reason, these are where we see almost 80% of the pathologies in the spine, we see it in those 3 levels. Or 70 maybe %. Why are pathologies of the thoracic spine rare? Because it doesn't move much. And on top of that, the orientation of the facet, it locks them. Top of that, you have the rib cage that as well, like internal brace, protect that. So that fact is true that thoracic spine is generally more stable, has less motion, and you can take more bone away before it starts complaining. But I'm going to stick with my rule of thumb that if you take the entire facet off and violate the disc at the same time, you're rendering that segment unstable, iatrogenic instability. So let's come back. to reason for we do surgery. Easy now. Compression, you decompress. Instability, you fuse.
Mhm.
Now, Dominic, explain to me what you understand under each of these categories. Decompression versus fusion.
Okay. So decompression, usually, of course, we have to identify what is doing the compression. And a lot of times it could be a disc, and that's where we can get microdiscectomies and whatnot. We just we have the herniating part, we remove that part, and there you go, less compression.
Mhm.
Now, when fusion comes into play, a lot of the time I think more about the vertebral bodies themselves being part of the issue, not necessarily like the intervertebral body. All of the disc could be part of the problem because he's not doing his job. But really, I'm thinking if we're going to do a fusion, it's because I need these vertebrae to be a specific way so that way we can either open up the facets or we can give you stability. That's what I think from those two.
Okay, let's talk about this specific case.
Okay.
Dr. Arya, what do we see and what symptoms are you looking for? What sign in the CT and, or, I'm sorry, MRI you're looking for, and what should we do?
So there's a disc protrusion or a disc bulge at the L4-5 region.
Mm-hmm.
Paracentral on the right side. So I'd look for right-sided radicular pain.
What segments?
Also, primarily, so this is 4-5, mostly in the L5 distribution, so to the dorsum of the foot, big toe.
Mm-hmm. But there is a foraminal stenosis. Definitely, I see that protruding as well to the foramen. So mostly L5, but some L4.
No, some L4.
Now, inside of the facet, is it white or dark?
It's dark.
Is it good or bad?
That is good.
That is
Some
good.
people say
Yes.
white means that there's some motion, diastasis.
Now, white means there is a fusion. That white means there is water in that
Water.
facet. The water, the proton in the water is that in T2 turns up hyper intense, white. So meaning this is a good facet. Look at the inside of the L4-5 disc. Is it white or dark?
It's gray.
Well, I would call it white. And that white indicate there is hydration in that disc. The disc distance is not much different than the one above it. It's not perfect. Now, this patient, again, this is just images. One of the things that I challenge everybody, and I have a lot of fights for that on LinkedIn. Amanda knows what I'm talking about. If you want to fix picture, go learn Photoshop. If you want to fix patient, learn to be a clinician. What does that mean? What do I mean with that? Amanda, what do you think what I mean with that?
I think that it means listen to what the patient is saying and listen thoroughly to all the patient's problems, maybe even before you look at the image and come up with conclusions.
Yes, examine the patient, fix the symptoms, fix the clinical symptoms, not the picture alone. But let's talk about this picture alone. This picture really shouts at me, just take the pressure off. Don't fuse me. Correct? Because the problem seems to be compression. Now, we talked about instability. What are signs of instability, both in the pictures and on the patient? So, pressure or instability, or both? What do you think, Dominic? This patient, are you able to see my screen? Does this patient have instability or compression, or does this patient have both?
I mean, this space looks good. I would say some compression, but I'm not.
Compression, okay. Dr. Arya?
There might be a little instability on the 5-1 region.
A little instability? This is almost, if you measure it carefully, high grade 1 spondylolisthesis, isn't it?
Yeah, but there looks like there's some kind of osteophyte or bridging ankylosing.
Yeah.
I don't know on this one view.
Yeah, well, what does this instability means? Let's identify what instability means.
So instability is usually on dynamic images where you have more than, I think, 3 millimeters of motion, or I think it's 4 millimeters or 1 degree. There's specific radiological criteria
Mhm.
of change between flexion and extension,
Okay.
or changes between an MRI where they're laying down and an X-ray when they're standing up.
Mhm.
Oh.
Well, I would, again, that is a traditional textbook, orthopedic and so on, definition of instability, where spine moves the way it's not supposed to move. Like imagine you open a door to the side, you open the hinge door to the side, you open it to the side. Now imagine like Bugs Bunny and one of those cartoons, the door opens down. Okay? So I would challenge that old way of looking at instability as just that many millimeter in this view and that view and so on. Now a Jenga, what is that? What is that game that you take the pieces out until everything collapses? What is that game is called?
Yeah, Jenga.
Jenga?
Yeah, one little block at a time, and you hope the person after you screws up.
Yeah. That is for me what instability is. Not that the Jenga is moving, but there are signs that Jenga, the next piece, that everything is going to fall apart.
Okay.
What are those signs? Now, traditionally, you order a lot of them for us, Dominic. You ask the patient bend forward and backward, flexion extension, to see if it's moving the wrong way. You can have that what we call mobile or immobile spondylolisthesis. Now, instability, then that is why I say we are going to write the textbook, not just read them. Instability for me is that Jenga is about to fall and you want to prevent it of falling, because once it falls, you're done. The damage is done and so on. Now, what are the signs that spine is unstable in our definition, not in a traditional 3 millimeter mobile, broken bone, and so on? What is in our definition sign of instability in the pictures? Obviously, spondylolisthesis is one of them.
Yeah.
That is unnatural for any bone, any segment to have a axial slippage of the disc. And we grade that. Dr. Aya, what are those gradings for spondylolisthesis?
Grade 1, 2, 3, 4, and then apoptosis. Not apoptosis. There's another word for when it's just completely off.
Mm-hmm.
To...
So if it 25% is grade 1, more 25 to 50% grade 2, and so on and so forth. Now,
yeah.
What is look at this picture. The other sign of instability is what we call the spinal parameter, and there are tons of it out there. We are not going to go over them today in this podcast, but when spine have a shape that's not natural, meaning that is the Jenga that you see, there are lots of pieces are missing, you know this is not stable by itself. It just needs a little bit of a push in any way to fall apart. When we talk about instability, I want you to consider that Jenga, that you know it's going to fall off because you look at it, is unstable. Now, what is unstable? What makes you feel that Jenga is unstable? This is what we are talking about. Spondylolisthesis is one of them. Other one is so-called scoliosis. Dr. Ari, do you want to describe what you see here?
Sagittal and coronal views of a lumbar spine, T1 image on one and T2 on the other. And then on the coronal, you can see that there looks to be about a 5-10 degree right-sided scoliotic curve in
Um,
the lumbar spine.
Let me give it to you that you're looking at the muscle. They're so nicely thin, and the fat is white on both of them.
So they're both T1.
No, this is T2,
Oh, T2.
right? And here, look at the fat and so on is white. But look at the inside of the disc.
Mm-hmm.
It is so it is most likely, I believe both of them are T2s. But yeah, you have to look at more picture than one to say that for sure. Now, look at the Dominic, between this disc and this disc, is there, if I put a line between these two discs, do you think that those lines would be parallel?
Yeah, just about, just about.
But if I put a line between this disc and this disc, those lines would not be parallel, right? They would have an
Yeah.
angle.
Only if you closed your eyes.
What would we call that angle? If I would put a line here, and there is this dotted line make an angle.
Gotcha, yeah.
What's the name of that angle?
It's our little Cobb angle, you know, COB,
Cobb
like corn on the cob.
Yes, yes. Okay. So you see the Cobb angle by itself is in a traditional definition wouldn't be instability. But again, if you take that Jenga, the kind of analogy, you understand that there is more pressure on one side versus another of this disk. And that situation is not sustainable. Now, Dr. Arya, do you think I would looking at this picture, do you think this patient needs surgery? And if yes, what kind of surgery?
Without the clinical correlation or the symptoms, based on just the images, there's no signs of instability.
Okay, so let's say patient has only claudication symptoms. What would we do?
Okay, so if they have claudications, I'd have to look more on the axial, but it looks like that could be coming from the 5, 4, 3, the 2, 3 region. That looks like where on the sagittal view you have the most arthritic changes. So traditionally, a lot of people would say you have to do the whole curve, but nowadays more and more people are doing segmental fixation of just the acute or the problem angle. So you could potentially get away with a 2-3 isolated fusion.
Okay, well, let me again challenge the status quo a little even more. Traditionally, you're right. I get all this the Lincoln barrier that they say to correct it and so on. You have to do thoracic to think, fix everything, do the 14-hour surgery, gallon of blood loss, 4 days ICU stay, and the 40% risk of infection. And yes, we do segmental fusion very successfully. But let me just tell you, if the claudication is the only symptoms, if this patient doesn't have back pain, I would do a foraminal-laminotomy. I would not even fuse. Now, if during the if patient has claudication is a sign of compression, that means anywhere where we have cauda equina, if all those nerves are compressed together, you get symptoms of compression of the entire nerve, not just one nerve root. That's what claudication is. I would just open up the space. But if this patient has significant back pain, then I would do fusion. Now, if looking at all the pictures, the compression would destabilize the spine, then I would do a fusion. Go ahead, Dr. Arya.
That's where surgeon skill also comes into play, because I haven't seen the axial, but if the axial corresponds to what I'm seeing on the sagittal, then I know in my hands, especially if that's the apex of the scoliotic curve, that just like the game of Jenga, I would probably remove too much bone to predict, to reliably be sure that this person won't have instability within 5 years. Okay. So for me, I would automatically say you're going to need a fusion.
And that would not be a wrong answer, and that would be the classical answer. And but again, we are going to write the future textbook. Now, there are lots of methods these days that, like laminotomy, like a endoscopic. You can, if you can, let's go back one step back. You remember, if you take more than half of the facet and touch the disc, you are making it unstable. Can you do a decompression? Let's assume this patient has only claudication, only compression symptoms. Is there a surgery that you can do without taking more than half of the facet and not touch the disc? If you have that in your hand, if you can do that, decompression could be the right solution for this patient. If you don't have that tools, then fusion is the better surgery for this patient, because you created an iatrogenic instability. Even though initially patient didn't have any clinical sign of instability, you created that.
Right. And it's also important to remember, like up higher in the lumbar spine, you don't have that much, the real estate is very different from down in the lower lumbar spine. The threshold for error is much, much less.
Correct. That's why we become more aggressive to remove bone, so we are not close to the nerve. So let's talk about this patient.
Actually, we'll save that next patient for our part 2. We're at the end of our session here. So we do have another meeting in 3 minutes. So unfortunately, you guys will have to tune in next week for this patient.
But let's just come back and recap indication for the surgery. First of all, we maximize non-surgical treatment. Then we get the pictures, and then we correlate 2 things in the pictures with 2 things in the patient: the signs of compression, the signs of instability. If we can decompress and achieve clinical improvement, we decompress. If patient has clinical sign of instability and radiographical sign of instability, or if our decompression produces an iatrogenic instability, then we fuse. Now, and that sort of sums it truly up for our indication of when do we do spine surgery and what kind of spine surgery. Now, coming back to that, don't forget, consider instability not in a classical sense, but in a Jenga sense. And let's just frame the word, Dr. Aya. Let's call it Jenga instability. Instability is still up, but the next move is going to bring everything down. So I think that should suffice for now.
Thank you guys for watching. This was Essence of Medicine. We talked about who needs spine surgery. I'm Amanda Armagost.
Dominic Moore.
Dr. Aya, you have to.
Oh, Dr. Aya. Hi.
And here's Dr. Abbasi for Essence. Thank you for watching us.
Thanks, guys. Be safe.